Hi, everybody. My name's Diane Meier. I'm the director of the Center to Advance Palliative Care, and it's a real pleasure today to introduce our first plenary speaker of this year's 2x4 gathering, CAPC's first attempt at a virtual national meeting. I'm really thrilled to introduce Harry Cho to you. Harry is a colleague of mine from New York City and a leader at New York City's Health and Hospitals Corporation, which is the largest public health system in the United States. And we invited Harry to give this plenary because he exemplifies the kind of future-looking leadership that we hope to inspire our field with, that we hope to encourage and support leaders and team members on palliative care teams to pursue a similar systems level influence and role in healing our healthcare system. I think it's obvious to everyone that the pandemic, the COVID-19 pandemic, is forcing major changes in the US healthcare system. People are recognizing that our reliance on fee-for-service reimbursement for elective procedures is not a very safe basis for maintaining a healthcare system. Because when those procedures were shut down because of the pandemic, healthcare systems lost their major source of income. And when healthcare systems lose their major source of income, they lose the ability to serve the community. Those systems that were funded globally, that is, had an annual budget like the VA or Kaiser, or health systems that were heavily engaged in value-based delivery of healthcare, were not hurt in the same way that those that were predominantly reliant on fee-for-service were. And it's definitely leading to a change in thinking about what is a sustainable financing model for our US healthcare system. So it's clear that leaders in the US healthcare system have to start reprioritizing. And palliative care teams and palliative care clinicians should view this as an opportunity to establish stronger relationships with our leaders and to be partners to those leaders in the rebuilding and the re-envisioning of the healthcare system of the future. So we invited Harry Cho to talk with you about his experiences as a leader and becoming a leader in the health system in which he works. And we especially asked him to focus on what were the characteristics, what were the things that he did that he saw as key to his ability to be an effective leader, and what were the things that he didn't do that perhaps he should have done to become an effective leader. We are learning from his experience. And one of the points he makes, which I hope you will all take away from this session, is on the importance of relationships and of consciously building and connecting with partners in a huge spectrum of functions in the healthcare system, and that those relationships are the catalysts and the energy that enables change and that enables leaders to successfully implement change. Harry has had so many awards and honors that I can't list them all for you, but he's had more than 50 of them. He was named in 3 national 40 under 40 lists and received the Society of Hospital Medicine's Award of Excellence in Clinical Leadership by Physicians, the AMA's Excellence in Medicine Leadership Award, and the Top Hospitalist Honor from the American College of Physicians Hospitalists. So it's really an honor and a pleasure to introduce you. Welcome, Harry.
Hi, everyone. I'm Harry Cho. I'm a hospice physician by training, and I'm also a chief value officer in terms of my administrative duties. And I work at New York City Health and Hospital System, which is an 11 hospital safety net system based out of New York City. Most of my work is quality and safety implementation. And basically, it's how to create change across a large health network and sustain it. I thought I'd walk you through a couple of ways of how I view things, particularly now during this pandemic. Since our first cases in January 2020, this is what most of us look like on a daily basis. Eyewear, face shield, mask, a gown, 6 feet apart. Voices are muffled and eyes are behind a reflective glare. A huge proportion of the way we communicate, which is our facial expression, showing approval, empathy, support, frustration, or anger, is literally covered up. And for many of us, this is what our interactions with our colleagues and our teammates look like. Department meetings and work groups, educational lectures, and even birthdays and team celebrations are done virtually like this. And think about how these virtual meetings go. Can everyone put themselves on mute? There's a lot of background noise. Can you hear me now? I think you're on mute, Bob. And it would be helpful if everyone was actually on video so that we can see their facial expressions and see if they're paying attention, whether they're frustrated or just plain bored. But most people aren't. And even worse, many may not even be paying attention or maybe multitasking. If you can imagine this in-person meetings, imagine if someone is sitting there across from you at the meeting and just typing away at their laptop on their notes or checking their phone. Distracted, distanced, less engaged. It's harder to bring people together. We are losing some fundamental ways to form trust and meaningful relationships. And relationships are started in person. It starts with that handshake, the one-on-one setting, listening, sharing, being vulnerable, and connecting. Understanding their values, their worries, and who they are as a person, where they're from, what brought them into healthcare, who their family is, and what they enjoy doing for fun on their free time. As an administrator, I love to meet people at their office and their place of work. And it is important, and I genuinely want them to know how important they are to me as a person, colleague, and a friend. And relationships are difficult to start virtually. Take, for example, dating apps. In the past 10 years, the way that we date and meet people have changed drastically. Instead of meeting people in person from the get-go, now it's done over the phone. And you're looking through the personal bios and you're swiping left and right. And then it starts with a text, back and forth, but ultimately, in order for the relationship to start, you have to meet in person. It's very similar in other situations. Think about our conferences that we go annually in national venues. You can email, retweet, and do conference calls with your colleagues across the country, but it isn't really until you meet them at the conference that you feel like you know someone. Something about the excitement of like-minded people coming together, sitting in the same area, talking and sharing ideas that makes the in-person experience worthwhile. Think about the live concerts and sports games. Enjoy the in-person excitement instead of listening and watching from home. And trust and relationships require upkeep. Take the group meetings in the past. It's the few minutes as you're sitting around the table waiting for the meeting to start. While sitting next to a colleague and you sort of mention to the side, hey, I heard your lecture last week. It's really great. Or, hey, I heard your daughter was in the hospital the other day. Is everything okay? After the meeting, walking the lines alongside them in the hallways and catching up. Those are important. Those are how we build trust and meaningful relationships. But now we have less and less of those moments. And this new shift is very difficult and troubling. We are also relying on more written forms of communication in order to get work done. Think about our emails. The short replies, the no's, the critiques, the disagreement, perceived the wrong way, leading to mistrust and frustration. And it lingers deep until you actually meet them the next time and realize that they didn't mean it. And they're your friends and your colleagues. We tend to state things to others that we wouldn't say in person over email. Emails and written communication take the power of sound, away. Intonation, pitch, the fillers. And research has shown emails are 2 to 3 times more likely to lead to disagreement and negative views. This is why we say never give feedback over email. And studies show that when you want a yes from another person, you're 30 times more likely to ask in person to get that yes versus an email. And then think about email has changed over the years. In the late 90s, I still remember getting on this dial-up modem. It's on this desktop computer was really large. You boot it up, you use that dial-up modem with the crazy sounds, and you call in and you wait for minutes. You log into AOL with your screen name. And it takes a while, and once you get in, you're looking, you click that email button, and it's waiting for that sound. You got mail. And used to be very, very few people that you connected with well, right? Emails were only a few, and you were looking for basically your friends, your best friends, and your closest family members, your significant other. These emails used to be long paragraphs talking about your day and how it went, talked about your feelings about these certain things. Now, network is huge. It's dozens, hundreds of emails a day. I still remember here in New York City when the surge hit, and we were at a peak in the first week of April. Around the city, there were 800 patients dying per day. There's a lot of uncertainty, a lot of fear. And I was on the floors at Bellevue seeing patients, and the service was packed. ICU was 4 times capacity. And what I would try to do with my administrative duties was try to see 2 or 3 patients at one time, step out, look through my emails to make sure I'm not missing anything in terms of coordinating things across the system to help others. And I would look down, and after 45 minutes of breaks, just look down and see the 20 to 30 emails. You can imagine the way we communicate during surges like this when things get busy. Skim them, you might gloss over them, you may not even reply, but if the replies do happen, it's short, yes, no, I disagree. And these can be misconstrued. So, taking all this together in this world of abstraction, if I could give one overarching advice, it would be this. Because we are more isolated, because we are more distanced and masked, because we don't have the usual moments in between to catch up and check in with each other, we need to carve out ways to build trust and connections. After a meeting, on Zoom, take the 5 minutes, call up just one colleague, call up a meeting, and just call them and say, hey, I saw you on the call. What did you think about that proposal? And by the way, how are you? I haven't seen you for a while. That one-to-one connection there is incredible in terms of maintaining that trust and that relationship that you have, because we just don't have other opportunities. Or if you happen, or anything else that's in terms of one-on-one that you can give encouragement, follow up with a quick email or the text to the other person saying, great presentation there, really did a great job. Or better yet, if you can be in person, do it there. We know this. In person is much better. Be safe. Have your mask on, have 6 feet of distance. But the one-to-one moments that you have to connect are incredibly important to do this. And nothing in healthcare is done alone. Everything requires working together with the team. And breaking down walls to support our colleagues and our team is important more than ever in this pandemic. The more virtual and distance we are, the more we need to find focused ways to connect with each other. So I do want to go through with you about this connection and next in terms of how I look to implement ideas and quality improvement initiatives across the system. This is from Everett Rogers, Diffusion of Innovations. I'll walk you from the left side to the right. This is how ideas spread across the population. On the left side is the 2.5% of innovators. Then comes the 13.5 early adopters, then early majority, late majority, and then finally you have the laggards. Some of the most common examples of this, for example, if there was a new iPhone that came out, the early innovators on the very far left, those would be the ones who already know exactly what the new innovations or what the new features are of the iPhone. And they'd be waiting in line the night before around the block. they live and they identify themselves as being the first. On the very far side, the laggards are probably the ones who are still using touch-tone phones or the push buttons, and the only reason why they would buy a smartphone is because they don't sell the other ones. Taking this concept, there's one key thing here. This is called crossing the chasm. It's 15 to 18%, so it's the innovators and the early adopters. And once you can spread an idea past this chasm, then the diffusion of innovation says that you can spread the idea across to the rest. The early majority, the 34% that are on the right side of this arrow, this chasm, they are the pragmatists. They are waiting for the early adopters on the left to try it out, to vet the idea, to see if it's good, and then they follow. Now, how do you get past that chasm? Malcolm Gladwell, in his book, The Tipping Point, identified 3 archetypes, or 3 types of people that are really good at doing this. First one is the connectors. So this is the networker. These are usually extroverts and who are really good at connecting with people and just thrive and love knowing people and connecting them together. They know who the experts are, who are the leaders in this, and they just are very good at remembering people and learning to connect with them. Next one is the mavens. These are the content experts. If you can remember sort of in lectures and morning reports, in case conferences, these are the content experts that are evidence-based, that have read the recent journal article that came out, can spew out numbers, and are the people that that others go to for just the pure knowledge because they're well-versed. Third type are the salespeople. These are the persuaders. They're usually the most dynamic, they're the charismatic, the ones that can sort of go in front of crowds and other people and just persuade them that what they're talking about is more important. And they feel passionate about this. These 3 types are what he identified as the ones who can cause this change, this spread, and get people and get ideas past the chasm. Just in my personal experience, I think connectors, mavens, and salespeople are incredibly important. They're not the only ones, and I do feel like this last category of doers are really important here. Who are these people? Naturally, when I go from one hospital to the next and I'm trying to enable change and move a project across, whether it's reducing readmissions for heart failure patients, you start to look at who you need to start talking with first. Is it the executive leads? Is it the chairs, chiefs, and directors of divisions and sections? Perhaps, but not necessarily. Is it the associate directors and the nurse managers? And more likely they are. And lastly, it's the frontline leaders, the clinical leads, who everyone respects, who want to get things done. From start to finish, they work well with others, rallies teams, rolls up their sleeves, and just owns it to get the job done. And the key thing here is that they devote time and consistency to the initiative. And these are the change agents. It's not the title itself. I need them to nod. I go to chairs, I go to executive leads to get their buy-in, to give them the nod so that they can point me to the frontline leadership. But ultimately, those are who I connect with and work with the most, and who I like to spend the time supporting. And underlying all of this, it goes back to trust. Who is it that I can trust to get this done? Who is it that I trust to tell me the truth and connect and are willing to give the time and the consistency to do this? Do you want to share that in my past experience, there's this odd response, this top-down ask. If I need to do an initiative for readmissions, there's this sort of odd response. If I ask for this and I set up a meeting over a phone or in person, some people say, yes, we're willing to do it, and they mean it. Those are great. Some people say, no, we're not ready for it, this isn't the right for us, and they mean it. And I appreciate that. Then there's the odd in-between that I call the slow no. They sort of say yes, they drag it from one meeting to the next, they show up for one meeting and maybe don't show up for others, And next thing you know, a couple months go by and I lost a lot of time and effort trying to give support. And this is the tough part. It's trying to find these sort of change agents and how they are key in making this happen. So during the surge in New York City, one of the things that we did was quite scary, actually. I remember being back in March and April and the unknowns and our own staff sort of falling ill to COVID. And we've also lost some of our staff too. And trying to sort of reorganize and expand our services and trying to make sure that we have enough PPE and trying to help our patients. And we called this volunteer of in-person volunteers across the country, across the state, to come to New York and support us. One thing that was missing was palliative care. And we realized very quickly that this was going to be incredibly important in supporting our frontline staff, in trying to connect with our patients and supporting them at the end of life in terms of symptom management. And also just trying to connect with their families at home who could not come into the hospital, who could not call in, who couldn't see them. And this was important. I remember sending this tweet out in the first week of April, just asking for help and trying to enable this process of crowdsourcing this palliative care help from across the country where the surge was not evident and providing this support for our frontline clinicians. And this was key. We had very short time. I had a small staff. I was also going in and out of clinical duties. And the key here, out of our 11 hospitals, was trying to find that clinical lead that I could connect with. I went to the executive leads. I went to department and division chairs. And once I found that clinical lead, this was the most important. This is the person that I was talking with on a daily basis. And they would tell me what it looked like on the ground and how they can actually connect with the clinical volunteer, with their own sort of staff on the ground, with their own needs, and tell me how I can support them in order to make this resource helpful. It was exciting, but these are the change agents that we need. Now the question comes up to administrators, what are the priorities? What are our priorities for systems? And I think this is a tough one to answer right now. I'm not sure even if I answer, I'm not sure it'll be applicable for the rest of you. The CAPC survey for the impact of COVID-19 on palliative care teams was sent out, 1,500 organizations back in May, 240 respondents, and the top 8 concerns are not surprising. Among program leaders, telemedicine sustainability, burnout on the team, financial viability of the service line. Across the board, because of COVID, financials for most health systems are not doing well. This is not surprising. Furloughs, layoffs, this is across the board, and private, nonprofit, and academic are facing this crisis right now. And my answer to this is yes. What are we prioritizing? Yes, if there's anything that aligns with ROI or return on investment that can bring in more money to cover this deficit, yes, that will turn heads. Value-based purchasing, length of stay, readmission, press gain scores, all those things, including telehealth, psychological safety, and equity, are all important. But having done this many times before, having started initiatives failing, and sort of going back and forth, what we're looking for is what you feel is important. The outcomes for patients and families that you feel is meaningful. Quantifying that outcome and implementing and sustaining that change is ultimately what we need. We're looking for the long game, the relationships, the frontline clinician champions. Once we have those change agents, that's what we'd like to support, find other targets, and continue to build the foundations around them so that we can build better programs, change the outcomes, and eventually deliver that ROI that we need. I think palliative care clinicians are one of the most supportive and caring groups of healthcare workers in the field. You are the specialists that people trust. You're the ones that are the most emotionally intelligent and understand how to build key connections with other people. And that skill set is incredibly invaluable in this time of COVID. We're more distant and isolated from our team members than we can't afford to be. Nothing in healthcare is done alone. We have to work together, and the arbitrary walls that divide us as healthcare workers between disciplines, between hospitals, are are growing larger during this uncertain time. And this is where we need to build trust. We need to bring people together to create these changes for patients. We need our connectors, our mavens, our salespeople, and most of all, the doers to lead the charge. Thank you very much.